Personality can be defined as an ingrained, enduring pattern of behaving and relating to the self, others, and the environment. It includes perceptions, attitudes, and emotions. People are not generally aware of their own personality. Personality disorders are diagnosed when there's an impairment of personality functioning and personality traits that are maladaptive. Be sure to read the DSM criteria in your book and post it in the module. Maladaptive or dysfunctional personality traits may include negative behavior towards others, anger or hostility, irritable and labile moods, a lack of remorse or guilt, impulsivity, distractibility, or poor judgment, not accepting responsibility for their own actions, engaging in risk-taking behaviors, mistrust, exhibitionism, dependency, and eccentric perceptions. A person with a personality disorder will not have all of these traits. Rather, the traits that are present are the basis for distinguishing one personality disorder from another. Personality disorders are not typically diagnosed until the person is an adult. Prior to that, personality is still developing. Personality is very difficult to change, and people tend to continue to behave in the way that's familiar to them, even when it causes them trouble and distress. We cannot medicate personality, and therapy used to treat personality disorders is long with slow progress. Some don't see the need to change their behavior, as they see the problems as coming from others around them, not themselves. This makes them very difficult to treat, which can be very frustrating for those around them, family, friends, or the nurse. Personality disorders are organized according to clusters around a predominant type of behavior. Cluster A is odd or eccentric behaviors and includes paranoid personality disorder, schizoid personality disorder, and schizotypal personality disorder. Cluster B is erratic or dramatic behaviors and includes borderline personality disorder, antisocial personality disorder, narcissistic personality disorder, and histrionic personality disorder. Cluster C is anxious or fearful behaviors and includes obsessive personality disorder, avoidant personality disorder, and dependent personality disorder. The two we see most often in the clinical setting are borderline and antisocial personality disorders, so these are the two that we'll focus on. Personality disorders are fairly common, occurring in about 10 to 20% of the general population. In the inpatient setting, the incidence of those with a primary diagnosis of a personality disorder is about 15%, and those with a coexisting personality disorder is about 40 to 45%. This can complicate treatments as personality disorders can be treatment resistant because personality and behavior can be deeply ingrained and difficult to change. Those with a personality disorder also have a higher death rate, particularly due to suicide, both in rates of completion and attempts. They can be difficult to live with and may have higher rates of separation, divorce, and other legal issues. Those with a personality disorder may also not see their behavior as a problem and don't see a need to change. They feel that it's worked for them so far, so why change? Etiology. The biologic theory states that personality develops through the interactions of hereditary disposition and environmental influences. Temperament refers to the biologic processes of sensation, association, and motivation that underlie the integration of skills and habits based on emotion. There are 4 temperament traits: harm avoidance, novelty seeking, reward dependence, and persistence. Each trait will affect a person's automatic responses to certain situations, and the response patterns are ingrained by 2 to 3 years old. The psychodynamic theory states that character consists of concepts about the self and the external world. It develops over time as a person comes into contact with people and situations and confronts challenges. There are 3 character traits: self-directedness, cooperativeness, and self-transcendence. When we're looking at a person's personality, we need to take into consideration their ethnic, cultural, and social background. Some may be guarded or defensive because of a language barrier. Some with religious or spiritual beliefs, such as speaking in tongues or evil spirits, may be thought to have schizotypal personality disorder. Some cultures encourage deference, passivity, and politeness, while others value work and productivity. Typical gender roles in various cultures also need to be considered. There are several strategies used to treat patients with a personality disorder. A combination of medications and therapies, group or individual, is more likely to be effective than a single treatment. Pharmacological treatment focuses on the patient's symptoms. You can't medicate a personality. There are 4 symptom categories: cognitive perceptual distortions, affective symptoms and mood dysregulation, aggression and behavioral dysfunction, and anxiety. We may see medications like lithium, carbamazepine, valproic acid or Depakote, haloperidol, SSRIs, risperidone, olanzapine, and quetiapine. Goals for therapy include building trust, basic living skills, providing support, decreasing symptoms like anxiety, and improving interpersonal relationships. Groups may teach coping skills such as relaxation or meditation. Cognitive behavioral therapy, or CBT, helps with thought stopping, positive self-talk, and decatastrophizing. Dialectical behavioral therapy, or DBT, is designed for borderline personality and focuses on the person's distorted thinking and behavior based on the assumption that poorly regulated emotions are the underlying problem. Paranoid personality disorder is characterized by pervasive mistrust and suspiciousness of others. Incidence is approximately 2 to 4% of the general population and is more common in males than females. Patients may seem aloof and withdrawn, guarded, or hypervigilant. Affect may be restricted, and mood may be labile. They may feel attacked by others and use sarcasm. They may use the defense mechanism of projection or blaming others for their troubles. Nursing interventions can include using a formal business-like approach with the patient, being on time, keeping commitments, and being straightforward. Be sure to involve the patient in their plan of care, as they're more likely to follow it if they feel they have some control over what happens. Schizotypal personality disorder is characterized by a pervasive pattern of social and interpersonal deficits marked by acute discomfort with and reduced capacity for close relationships, as well as by cognitive or perceptual distortions and behavioral eccentricities. Incidence is about 3% of the general population, and it's slightly more common in men than women. Appearance is often odd, unkempt, and disheveled. Clothes may be stained and dirty, ill-fitting, and may not match. Emotional range may be restricted, and affect may be flat or inappropriate. The person may experience ideas of reference, magical thinking, preoccupations, or have odd beliefs. They may be anxious around other people and have limited capacity for close relationships, frequently having only one close relationship that's usually with a first-degree relative. Nursing interventions will include a focus on self-care, social skills, and improved ability to function in the community. The nurse can help them establish a daily routine and to identify those in the community they need to interact with, such as a landlord, grocery store clerk, etc., and help role-play interactions with these people. Schizoid personality disorder is characterized by a pervasive pattern of detachment from social relationships and a restricted range of emotional expression in interpersonal settings. Incidence is approximately 5% of the general population, and it's more common in males than females. Affect is likely to be constricted or blunted or flat. The patient may come across as aloof, indifferent, or emotionally cold and uncaring. They struggle to experience and express emotions, but usually have an extensive fantasy life. Typically, these patients do not want involvement with others, so they don't have friends, date, or marry, although they may have a connection to a first-degree relative, like a parent. Nursing interventions focus on improving the ability to function in the community. The nurse may involve social workers to help with housing and to help identify and maintain a support person for the patient. Antisocial personality disorder is characterized by a pervasive pattern of disregard for and violation of the rights of others, deceit, and manipulation. It may also be called psychopathy or sociopathy. It occurs in about 3% of the general population, up to 30% in the clinical setting, and in about 75% of the prison population. It's 3 to 4 times more common in men than in women. It tends to peak in the 20s and diminish after about 45. Those with antisocial are good at deception, so it's a good idea to check any information they give you. Onset is generally in childhood or adolescence. They may have a history of enuresis, sleepwalking, cruelty to animals, lying, truancy, substance abuse, and so forth. Family history may show depression, substance use, and antisocial personality. They usually appear normal, possibly anxious, but can be very charming. Mood and affect are often chosen to suit the occasion or to manipulate. Actual emotions are generally shallow. Thought process and content are likely narrow and distorted. They believe in caring for themselves because no one else will, and that it's a dog-eat-dog world. They have poor judgment and don't care about legalities, morals, or ethics. They're motivated by what they want, and they want it now, so they can be impulsive. There's also a lack of insight, and problems are viewed as someone else's fault. Relationships are difficult. They manipulate and exploit others. They may marry and have kids, but they have trouble with long-term commitment and are usually unsuccessful spouses. They may leave others abandoned. They get jobs easily, but their work history is poor. Absenteeism, theft, embezzlement, or they just quit because they're bored. Those with antisocial do not typically get treatment voluntarily unless there's some personal gain in doing so, like avoiding jail. Nursing diagnoses to consider include ineffective coping, ineffective role performance, and risk for other directed violence. Outcomes may include the patient will demonstrate non-destructive ways to express feelings and frustration, and the patient will achieve or maintain satisfactory role performance. Nursing interventions will likely focus on forming a therapeutic relationship and promoting responsible behavior. This may include limit setting. There are 3 parts to limit setting: stating the unacceptable behavior, identifying the consequences, and identifying the acceptable behavior. This may look like, you cannot continue to interrupt others in the group. If you continue to do so, you'll be asked to leave group. You need to wait your turn to talk. Remember not to be punitive when you set limits with a patient. You need to remain calm and non-judgmental. We also want to work on problem solving and controlling emotions. Problem solving skills may include looking at alternate solutions and possible consequences, and helping them identify sources of frustration and ways to respond to it. Borderline personality disorder is characterized by a pervasive pattern of unstable interpersonal relationships, self-image, affect, and marked impulsivity. It occurs in about 2 to 3% of the general population and is the most common personality disorder in the clinical setting. It's 3 times more common in women than in men and is 5 times more common if a first-degree relative has the diagnosis. 8 to 10% of those with borderline personality commit suicide, up to 3/4 self-harm. They can be very frustrating to work with. They love you one minute and hate you the next, manipulate, sabotage their own treatment, have labile moods, and have unpredictable behavior. Looking at history, about 50% have a history of childhood sexual abuse, while others have experienced verbal and physical abuse. They may also use teddy bears, blankets, and other security items into adulthood. Appearance may be normal at first, or they may be out of control. Mood is generally dysphoric, and the patient may report feeling lonely, bored, or empty. Emotions tend to be intense and not expressed productively. Thinking about themselves or others is usually polarized, going from adoration and idealization to devaluing and disliking. Judgment is impaired and they can be very impulsive and have a lack of concern for safety. They frequently engage in risky behaviors such as gambling, reckless driving, or shoplifting. Insight is poor and they have difficulty accepting responsibility for their behavior, blaming it on someone else. They may threaten suicide or self-harm and may complete suicide. Relationships are difficult, unstable, and intense. They fear being abandoned and can engage in desperate behaviors, including suicide attempts, to get and maintain relationships. Nursing diagnoses can include risk for suicide, risk for self-mutilation, ineffective coping, and social isolation. Outcomes can include the patient will demonstrate increased control of impulsive behaviors, the patient will demonstrate problem-solving skills, or the patient will be free from significant injury. Interventions include promoting safety, establishing boundaries in relationships, and developing a therapeutic relationship with the patient. Safety is always a priority, and those with borderline personality frequently engage in self-harm, so a no self-harm contract may be used along with teaching them ways to safely express their feelings. Boundaries also need to be established and kept to help the patient understand we are there to help them, but we are not their friend. Helping the patient learn to communicate effectively and control their emotions is also important. We may teach them skills such as journaling, thought stopping, delaying gratification, structuring their time, and more to help them in these areas. Histrionic personality disorder is characterized by a pervasive pattern of excessive emotionality and attention seeking. It occurs in about 1 to 3% of the general population and is more often seen in females than males. Those with histrionic personality disorder tend to exaggerate the closeness of relationships and dramatize minor occurrences. Speech may be colorful and theatrical, but descriptions are vague. Patients are very concerned about their appearance and may overdress and have a flirtatious manner. Moods can have rapid shifts, and the patient may be labile and seem phony to observers. Thinking tends to focus on themselves with little thought to others, and they are highly suggestible and will agree with almost anyone for attention. They will do almost anything to get attention, including fainting, falling, and complaining of various physical symptoms. Nursing interventions include feedback about the patient's social interaction with others and needs to include appropriate alternatives to their behavior. Social skills to include are appearance, eye contact, respecting personal space, and active listening. Narcissistic personality disorder is characterized by a pervasive pattern of grandiosity, need for admiration, and lack of empathy. It occurs in about 1 to 6% of the general population and is more frequently in males than in females. Inpatient treatment is rare unless there are comorbidities. The person's attitudes may be arrogant, with no ability to empathize with others. Thought process is intact, but they may ruminate and compare themselves to others. Insight is poor, and they're unlikely to see their own behavior as contributing to their problems. They may have a sense of entitlement and expect special treatment, then get angry or upset when they don't. Nursing interventions include patient education about medications, comorbid conditions, and any needed self-care skills. Limit setting may be needed for rude and verbally abusive behavior. Avoidant personality disorder is characterized by a pervasive pattern of social discomfort and reticence, low self-esteem, and hypersensitivity to negative evaluation. It occurs in 2 to 3% of the general population and is found equally in males and females. Patients may be anxious and have poor eye contact. They may appear sad, fearful, socially awkward, and easily upset by criticism. They may be unwilling to make requests, ask questions, or do anything they perceive as risky. They want closeness and intimacy, but fear rejection and humiliation. Nursing interventions include support and reassurance while helping them explore positive self-aspects. Education on positive self-take, self-affirmations, reframing, and recatastrophizing can be helpful. Dependent personality disorder is characterized by a pervasive and excessive need to be taken care of, which leads to submissive and clinging behavior with fears of separation. It occurs in about 1% of the general population and is 3 times more common in females than males. Patients may be anxious, pessimistic, self-critical, and have their feelings hurt easily. Mood can be depressed and unhappy, and they may be preoccupied with worries of being left alone to care for themselves. They have a hard time making decisions on their own and ask for advice and reassurance frequently. They'll do almost anything to keep and maintain a relationship, even if the relationship is not particularly good for them or even abusive. Nursing interventions include fostering self-reliance. This may include helping the patient identify their strengths and teaching reframing and decatastrophizing. The patient may need referrals for assistance with daily functioning if they struggle to pay bills, grocery shop, budget, etc. They may need education on problem solving and decision making, although the nurse must be careful not to make decisions for the patient or to give advice. Obsessive-compulsive personality disorder is characterized by a pervasive pattern of preoccupation with perfectionism, mental and interpersonal control, and orderliness at the expense of flexibility, openness, and efficiency. It occurs in about 2 to 8% of the general population and occurs twice as often in males than females. Patients may come across as formal and serious. They may answer questions in detail and report a need to be perfect beginning in childhood. Their emotional range is restricted. They can be stubborn and reluctant to lose control. They may be preoccupied with orderliness, schedules, rules, and lists. They struggle with judgment and decision-making. Insight is limited. Relationships can be difficult as the person struggles to express feelings and may seem harsh. Nursing interventions include assisting the patient to accept less than perfect work and teaching cognitive restructuring techniques. Personality disorders are not diagnosed in the elderly population, but they may persist into older age. Some people may stabilize and have fewer difficulties as they age, but some age badly and struggle. Those that always seem angry, unhappy, and dissatisfied can have strained relationships with their family and even alienation from them. Those with personality disorders are at an increased risk for depression, suicide, and dementia. The most common personality disorder to persist into old age are paranoid, avoidant, dependent, and obsessive-compulsive. Treatment for personality disorders generally occurs in the community and involves group and individual therapy. Treatment will focus on mood stabilization, decreasing impulsivity, and developing social and relationship skills. Patients may perceive unmet needs in a variety of areas, including self-care, sexual expression, budgeting, psychotic symptoms, and psychological distress. Addressing these needs may help them have a better sense of well-being and improved health. Children who have a greater number of protective factors are less likely to develop antisocial behavior as an adult. These protective factors include school commitment, positive peer relationships, parent or peer disapproval of antisocial behavior, a functional family relationship, and effective parenting skills. Working with patients that have personality disorders can be very frustrating, and you may feel angry. It takes a long time to change behaviors, and the patients may attempt to manipulate and test limits repeatedly. You can talk to your colleagues to help deal with the frustration you may feel when working with these patients. Remain consistent and maintain communication about the patients, as team consistency is essential to treatment.